Good morning. Thank you for joining us for this COVID-19 update. Today is Tuesday, February 2nd, 2022. This is Kathy Turner, Director of Communications for the Louisville Metro Department of Public Health and Wellness. Mayor Fischer is our host today, and joining Mayor Fischer are Dr. Sarah Beth Hartledge, Associate Medical Director of the Louisville Metro Department of Public Health and Wellness, Dr. Edward Miller, U of L Health, maternal fetal medicine physician and high-risk pregnancy obstetrician and chief diversity officer, and Dr. Stephen Patton, family medicine doctor and community medical doctor with the Institute for Health Equity, a part of Norton Healthcare, and Nurse Delanor Manson, CEO of the Kentucky Nurses Association. I'd like to remind everyone to please mute your devices, place your questions in the chat addressed to everyone. Mayor Fischer, I'll now turn it over to you.
Okay, thanks, Kathy, and welcome everybody. Thank you for joining us. So here we are entering our second February of the pandemic, and you'll recall it was a year ago when we were starting to roll out vaccines. So we were hopeful then that we were moving toward a better place, and we're certainly hopeful now that we're slowly but surely exiting a deep and difficult, frightening period of the COVID-19 pandemic. The Omicron variant has been incredible in terms of its infectiousness. This past January, we had 4 times the number of infections reported compared to the previous worst month. So it just speaks to the strength of the Omicron variant in our community. We'll get into the data a little bit more on that later. We also want to take today's press conference to celebrate the beginning of Black History Month and what that means, what that overlap means with the virus. The theme of Black History Month this year is about health and wellness. And so at the beginning of the virus and throughout the virus, there's been a lot of focus on health equity as it relates to disproportionate infectiousness and death amongst Black and brown communities across America. Fortunately, in Louisville, we have not seen that. We'll get into the details more of that later and talk about some of the reasons. We've long focused on health equity in Louisville. We created the first Center for Health Equity in the country some 15 years or so ago here in Louisville. So we'd like to think that had something to do with the results that we have. But again, we're going to drill deeper into that. So racial equity obviously is extremely significant in all aspects of life, but it certainly plays a huge role in the health of our citizens as well. So even before the pandemic arrived in Louisville, our city has long worked to understand the tragedy of racial health disparities, as I mentioned. So we went into the fight against COVID-19 with high awareness of the issue and knowing that the difference in life expectancy for Louisvillians who live near Shawnee Park in the west part of town is about 12 years fewer than Louisvillians who live by Tom Sawyer Park in the east part of town. And that was from our last health equity report before the pandemic. Now, I'd like to note this is the same all over the country. So this is not just a Louisville issue, it's a national crisis. So we've learned that truly building racial equity requires intentionality. And you've got to put the processes in place, drill it into your system, and track your outcomes if you expect to have any change. And that's what we set out to do, having that baseline knowledge with our response to COVID-19, starting back in early 2020. So here's a couple examples. As vaccinations became more widely available early last year, we created a diverse vaccine distribution task force to coordinate and facilitate the implementation, communication, administration, and reporting vaccinations in the city with a focus on equity. In other words, putting vaccines where they were most needed in the community to those that were the highest at risk. And that was much of our Black and brown community. In January, our city, led by Metro Public Health and Wellness, but with support from all across Metro and many compassionate partners, established LouVax, and that was the state's first mass vaccination site for COVID-19 vaccines. And within the tiers of groups eligible for vaccines in the phased rollout, we worked to ensure that equity was a focus in getting those first valuable shots into the arms. Now, Remember, now you can get a vaccine anywhere, but in the early days, they were highly sought after, but we wanted to make sure that people that were most impacted could get their shots the first. Then when the broadband site closed in April, we transitioned to community-based clinics and visits to homebound individuals. Again, equity was the driving factor in determining locations of those mobile vaccine missions. So from the beginning of the vaccine rollout, we heeded the concern also that Black residents had some Black residents had traditionally about the role of medicine and how institutional racism had impacted medicine and medical research in our country. And so that's a fact that you have to take into consideration when we're encouraging people to get vaccines. But if they don't trust the system that is delivering those vaccines, that is something that we have to be alert of. There's unfortunate and tragic history in our country with experiments like those at the Tuskegee study that are well known and live on and are a fact of life, especially in our Black community. So we have to be able to work through issues like that. So we partnered with the Louisville Urban League, Black faith leaders, the NAACP, healthcare leaders, among others, to share positive messaging about the vaccine. We also provided grants to nonprofits that focused their service on minority, immigrant, and refugee communities for hosting listening sessions where residents could ask questions, as well as those mobile vaccine clinics being present. Now, unfortunately, we continue to see a disproportionate rate of people taking vaccines in majority Black neighborhoods. So we continue to focus on that with intentionality and guarantee that lack of access to vaccines or information will never be the reason why somebody cannot get a shot. That's true for testing as well. So this past fall, we partnered with the CDC and the National Institutes for Health on the Say Yes COVID Test Initiative, which provided 500,000 rapid home test kits to residents of zip codes where rates of COVID were highest, vaccination rates were lowest, including many with majority Black and brown residents. And then our wastewater treatment analysis also helped guide us to these areas where there was disproportionate infections taking place. And to meet the latest demands of the Omicron-driven surge, we last month opened a drive-through testing site centrally located at Churchill Downs, as well as testing sites in the west at St. Stephen Church and closer to southwest at the Shively City Hall. So we continue to research and learn, and for that, we've been awarded by the Center for Disease Controls, the CDC, a $4.2 million health disparities grant to our Center for Health Equity. So that allows us to expand the city's Center for Health Equity to support data collection and analysis, community outreach policy, and equity work related to the COVID-19 pandemic. Week before last, I was at the U.S. Conference of Mayors winter meeting, first time we got back in presence or in person in 2 years. And as one of the sessions, obviously a lot of focus on COVID. And as I shared our story around the vaccine and the impact of disproportionality not being present in Louisville, it kind of blew the other mayors away because a lot of cities have been really struggling with this. So while many communities have seen these disparities from the dastardly virus, I'm thankful to say that we're not. And we have not from the beginning. So there are a lot of reasons for this. Some we still don't fully understand, but we do know that racial disparities can only widen if we don't focus on them and we don't work with intentionality, which clearly we've been doing, and I'm proud of our team for that. So we're always going to have a lot of work to do, but I appreciate everybody who's worked so hard to address racial health inequities in our community. Because as we've seen, this is truly life-saving work each and every day, but particularly when it comes to the pandemic. So before we get into the data, let's talk more about this with some of the leaders addressing health equity in our community. I'm pleased to introduce our panel. As Kathy did at the beginning, Dr. Edward Miller, Dr. Stephen Patton, and Delanor Manson. I want to thank each one of you all for being with us here today. So Dr. Miller, let's start with you. U of L Health made it a priority to bring vaccinations to underserved communities. You guys did amazing work and doing amazing work. So tell us a little bit what drove that project's importance to you, and then how you worked with churches, community centers, and JCPS to accomplish your goal.
So the team at U of L Health recognized as COVID was declaring itself as a national emergency, that there were longstanding disparities that disproportionately affected communities of color before COVID. And we knew that COVID was going to highlight and exacerbate these disparities even further. We also recognized the limitations of a large healthcare system and the fact that the work or the lack of work that we had been doing to get into those communities and be present could be breached by community partnerships. So we went into the churches, we went into community organizations, and we really strengthened those relationships. I think we partnered with over 60 churches in the community. We vaccinated over tens of thousands of individuals. And most importantly, I think we kind of what I call went back to basics. We brought our facilities, we brought our people to the community that needed it, as opposed to vice versa. And that was all the difference that so many needed. There were so many people that came in on the fence about getting vaccinated, and literally because they saw their doctor, their nurse in front of them for the first time, chose to become vaccinated. The work with JCPS was kind of phase two as the vaccine became available for teenagers. And we found that teenagers were really encouraging their parents and their family members to become vaccinated as they became better educated on the vaccines. And they became another tool that we used to help protect our community.
No, it was a beautiful thing to see, and you and I ran into each other multiple times throughout that, about a year ago. First Gethsemane, I remember the conversation we had there. It was just buzzing with activity, and it was a beautiful thing to see the healthcare community and our citizens come together for really what was a joyous moment there at First G on Algonquin Parkway. So I guess, describe the reaction that you felt that you were getting for the most part from community members.
I think it was as equally healing for us as it was for them. It was Work has been so difficult throughout COVID, but being able to have those opportunities and actually seeing people like Cry getting to get their vaccine or getting that opportunity to become vaccinated, seeing thousands of people lining up outside of the African American Heritage Center. I mean, I know we had so many volunteers that came in that said, I've worked 5 days this week, but I must be there on Saturday, because we got as much out of it as our community did.
Now, talk us through this. We're still getting some people vaccinated for the first time, so I'm not going to give up on that. But it's much slower than it was a year ago. So have you found any remedies, new tricks to convince people that they still should get vaccinated?
Absolutely. I mean, as you mentioned, the vaccine, we went from how do I get it, how do I access it, to now the people that aren't vaccinated that are coming into my office now are not vaccinated for a reason. And now I get to have a conversation about what that reason is, because I know that those are also individuals that are more likely to not be up to date on preventative healthcare screenings like colonoscopies and all of those things. And it's an opportunity to have a conversation that's not just about COVID, but about really maximizing or taking the opportunity to improve your overall health in general. So it's conversation, it's breaking down barriers, and it's breaking down reasons for apprehension, which are so layered and so different between West Louisville, other areas of Louisville, and all of the patients that we serve.
And then are you finding that time is helping with some of that? I mean, the vaccine's been out now, what, about 13 months, 14 months or so. So have you seen that help with dropping some of the resistance?
Absolutely, especially with our pregnant women. I think as we've had time, our pregnant women are, I think, we're some of the most concerned about becoming vaccinated, because they have the concern not only for their own safety but for their child. And I think as we've had years and have had more trials now that are enrolling pregnant women, we've started to see a lot more openness, a lot more informed questions, and fortunately, a lot more acceptance of the vaccine.
That's good. I'll ask Dr. Patton next after I ask this question to you, but here we are in 2020. Why in the world should there be inequities in healthcare outcomes? What's your observations on that?
I need like hours to answer that question, but it's layered, and it is The answer is so much about individual communities. The answer is so much about culture. The answer is so much about history. It's about access. I think one of the things that we all as healthcare professionals can learn from COVID is that when something affects the whole community, the community rises to the challenge to take care of it. But other things like preterm birth, you know, in Kentucky and in Louisville, we have a national grade of D in preterm birth, and that disproportionately impacts people. We have so many healthcare disparities with cancer rates in populations, hypertension, diabetes. And I think what we have to learn is if we don't put that same emphasis on solving those barriers as we did with COVID, we're not doing what we need to do to stop those disparities. So this is an example of what we can do when we put our minds to it, but it's also an example of where our priorities need to be, because we will move to a point where COVID's done, but those disparities will still exist.
And that's a great point. So I'm hoping, Dr. Miller, that as we transition out of COVID, if that's such a thing, or let's say when it becomes endemic, we can take our vaccine task force and really focus on community-wide population health and see if we can make the same impact on that, accelerate the impact on that as we have with our COVID success. So I know you'll be there to help, whether it's studying placentas or early births, whatever it's going to be. We appreciate that. So Dr. Patton, how about you? Let's kind of start with that same question again. We know the life difference between, you know, the average black and white person. There's no such thing as average, but the facts are undeniable. So where do you zone in? Where do you zone in when you take a look at inequities in healthcare outcomes?
Well, there are, like Dr. Miller was saying, there's a variety of factors, but one of the bigger things too is also talking about those social determinants of health, you know, housing, healthy food sources, childcare, finances, that can also play a role in the overall picture for health. You know, as one of my roles as community medical directors is to address those health needs in the community in underserved areas. My colleagues, I work with Dr. Narcisse, she's an internal medicine doctor and a pediatrician, and Dr. Maria Noda, she's a pediatrician, and she works in the Latinx community as well. And our biggest thing is really to get hands on the ground, provide direct outreach and care, and participate in neighborhood educational health programs. But so the key is just to educate and try to address some of those social determinants that can later on reflect why we are having seen those healthcare disparities, like Dr. Miller was saying, in the hypertension, diabetes, chronic kidney disease, and other realms of healthcare.
So amongst your many titles, Dr. Patton, one of them is the community medical director. And so you just described, I assume, what a community medical director does.
Yes, sir.
So now the Institute for Health Equity, that's part of Norton Healthcare, recently celebrated the opening of its new facility in the Russell neighborhood. So that's an extension of the work that you do. If you want to describe that a little bit more and tell us how that's going.
Yes, so been working with the Institute of Health Equity. Very excited. We recently got the brick and mortar November 23rd of last year. It's in the Russell neighborhood on the corner of 12th and Jefferson. It's a beautiful facility, but the main goal with the Institute of Health Equity is to really identify those obstacles and get them removed from. That's what's stopping people from having access to healthcare, and also trying to eliminate those healthcare disparities. So a big thing we focus on is getting people access to healthcare and working with those natural community leaders and organizations in the area. So in a sense, we're using the IHE, or Institute for Health Equity, as a hub for resources and networking with the people in the community to address some of those same factors that's causing the healthcare disparities, as we mentioned before, like the housing and childcare, finances, and transportation. So I'm really excited about it, and working with a lot of great people.
Well, I want to commend Norton for its focus on equity. You're seeing that from U of L Health also, Baptist, our Center for Public Health and Wellness. So for the media, I mean, it requires this kind of intentionality to get the results that we're doing. And it's been a big team effort. So Doc, are there any other initiatives that you want to talk about getting healthcare to underserved communities?
Really just getting out there to the people and, like I say, bring healthcare to the people rather than having the people come to you. It's been a big initiative for us. In late 2019, we opened a primary care office at the YMCA on 18th and Broadway, and this has really been a central hub for vaccinations, educating people, and screening tests. And this couldn't have been done without the people in the community and those leaders and organizations that are well trusted in the community. To have those people come out and support the cause, which really means a lot. Also, another thing is we have a second mobile prevention unit. Thanks to Norton's Foundation, they granted over $1.25 million in this unit. And what this unit can do is go into those underserved areas. We can provide those screening tests like mammograms, well woman exams, prostate screenings, vaccinations. So I think that's going to make a large impact in the community in the future. So very excited about that as well.
All right. Thank you, Doc. Now let's turn to the celebrated, highly celebrated Delanor Manson, the CEO of the Kentucky Nurses Association. Delanor and her team from KNA were omnipresent throughout the administration of the vaccines from Louvax throughout the community. We simply could not have done it without the Nurses Association. And Delanor is their fearless leader and has just been incredible for our city. So thank you for all that work as we start off on our conversation, Delanor. But so could you tell us a little bit about the Nurses Association and how you guys have been helping out throughout this pandemic?
Mayor, I really appreciate the opportunity to talk a little bit about the Nurses Association and our work with health equity as well. The Kentucky Nurses Association was established in 1906, and we're the only nurses professional group that represents and supports 89,000 nurses. And there are about 13,000 nurses in Jefferson County area. We've been working since before there was a vaccine in doing testing. We started doing testing in November of 2020, and we worked in collaboration with the health department, and they asked us to come to the table, and we came willingly. I mean, that collaboration has made such an impact on the community.
Well, and it's been very, very visible and highly appreciated. So talk a little bit about your career in nursing and the inequities that you have seen, those maybe that are narrowing somewhat, but what can be done, what's being done?
Well, I've been in nursing for a really long time, and I'm a retired naval officer. And in terms of inequities, I just want to share one little story. I was working in Albuquerque, New Mexico, and I was the senior nurse in the hospital, and I went to help a patient to alleviate a problem. And they asked me for the nurse in charge. And I said, well, I am the nurse in charge. Well, they called me a name and said that they wanted a real nurse. And those types of things still happen in today's environment. They shouldn't in 2022, but we have to work very hard, and as you say, intentionally, to address those types of issues. It is extremely important that in healthcare, that people who come into the healthcare system see people that look like them. And we need to do a much better job in recruiting people of color and minority healthcare providers. In Kentucky, we only have about 8% of the nurses are, 4% of the nurses are African American, and we are 8% of the population. And so again, there's an opportunity to recruit more minorities to the nursing profession. The Black nurses are never seen as leaders. I recall in many situations, even recently where we've been addressing COVID, that me being the head of the Kentucky Nurses Association was not readily accepted because I was an African American. So there's an opportunity for us to address those types of issues. Many of those issues include structural racism, as the doctors have mentioned, in terms of health disparities, but great opportunities for us. And I can honestly say that in Louisville, I think we're doing a pretty good job, but there's still a lot of work to be done.
Yeah. Well, it makes me sad to hear your stories, Delanor, and you've done an incredible job. And we love you in the community. And anybody that has these issues needs to get out a little bit more and needs to see how our Black nurses and all of our nurses just deliver just incredible care throughout the pandemic. And you and I were on the front lines of that, along with our public health team, and people are very appreciative of what you and your team do. So thank you. And I'm sorry you've had to bear this journey throughout your life, but you're making one heck of a difference. So thank you.
Well, Mr. Mayor, I'm not the only one. And the thing is for a very long time, we didn't talk about it. We just took it and kept moving forward because it was important for us to be on the front lines.
Well, and I think, like efforts like we've done as a city, like our Lean Into Louisville effort is designed so white people in particular can be comfortable talking about racism. And too often people just don't say anything, right?
That's right.
And so you have to take it. They don't know how to talk about it, and our society suffers as a result of it. In the meantime, though, you just keep doing your work, which is a real testament to you and all of our Black and brown professionals here in not just healthcare, but society at large. So thank you for that again.
Mr. Mayor, may I mention all the vaccine clinics that we've done and the testing clinics, the Kentucky Nurses Association? We've provided over 8,000 vaccines, our little team, and over 8,000 tests. We were also instrumental in recruiting nurses to work at LUVAX, and we even had nurses from all over the state to come and help because, as you said, it was the first one in the state. So I just wanted to give a shout out to all of those nurses who came to help us and continue to help us with the mobile missions.
Well, it's it. We couldn't do it without you, period. I mean, it's as simple as that. So it's just amazing to see how KNA just really rose to the occasion. Not surprising, but amazing. And one of the big challenges throughout the whole pandemic has been fatigue on our healthcare heroes, our nurses and our doctors and such. And that's one of the areas where we plead with people to please get vaccinated so you can respect the people that are working in this field that saves our lives. So tell us a little bit about your role now in the COVID-19 vaccination distribution task force. We assembled this task force at the beginning from hospitals, providers, nurses association, scientists, researchers, to make sure that we were addressing COVID wisely from the beginning and equitably from the beginning. So tell us a little bit about the task force and your role on it.
Well, first of all, I was honored to be asked to participate. I think I was one of two nurses. The other nurse is an epidemiologist. And I was really impressed with health equity being the primary way that we were looking at how we were going to roll out the vaccines. Actually, I was surprised, but I was pleased. And so the idea of how are we going to get the vaccines and make them available to people who don't have transportation, people who don't trust healthcare providers who don't look like them. How do we do that? And that was always part of the agenda. In fact, I think it was the first agenda item at every meeting. And Dr. Sarah Beth, I can honestly say that some of your discussion about how we needed to do more, how we needed to go to different places, and how we, as the doctors have said, need to go to the community and not expect the community to come to us. And so that task force has been, I think, the lifeblood of getting the vaccines and the testing out to the communities that we serve.
Yeah, well, thank you for your participation. I want to give a shout out to Bill Altman, who's been driving that along with Dr. Hartledge, and just amazing work, and it continues. So thank you all for all of your contributions there. For the media, please feel free to weigh in with any questions on that. So now let's transition to go through our latest data and take some questions from the media. Our case numbers, incident rate, hospitalizations, they're trending in the right direction. But as I said at the beginning, they're also woefully too high. They're at our highest levels ever. So the virus is still around us. They're coming down. So it's especially trouble especially if you're unvaccinated, okay? Because the pandemic is largely amongst the unvaccinated right now. So if that's you, please get the strength from this conversation today to talk to a doctor or pharmacist about your concerns. And if you're eligible, get for a booster, get that as well in addition to the shot. And then if you're tested and you're ill or have been exposed to someone who's been positive for the virus, please follow the isolation guidelines to protect yourself and those that you love as well. So let's hear from Dr. Sarah Beth Hartledge. You heard some great props for her earlier from Delanor Manson, who has been in the middle of all this, to say the least, and helped set up LUVAX and so many other of our initiatives. So Dr. Hartledge, what's the latest?
Thanks, Mayor. I just want to add, first of all, as the co-chair of the task force, I just want to say thank you to Delanor and our other leaders of diverse communities for coming to the table and helping find creative solutions to identifying problems and finding creative solutions to them. For the Encanto fans out there, we don't talk about Bruno, but we do talk about tough things. So I really appreciate that we are able to come together as a community and work through those things. So moving into the data, I get the privilege of being a little bit optimistic today. Our dashboard is undergoing some technical issues this morning. So here are the highlights for you. The past 7 days, we have logged 12,213 new cases. Which of course is still a very high number, but it is down. Last week was in the range of 14,000, the week before in the range of 16,000. So the incidence rate is now 227.5 cases per 100,000 of population. We have 467 patients in hospitals, 81 in the ICU, and 50 on ventilators. Last week, we did log 39 new deaths. And our positivity rate has finally dipped back below 30%, so it is on the way down as well at 28.4%. So I would say at this point that all of our indicators are that the worst of the Omicron wave is likely behind us. But of course, many lives are still being impacted by this virus every day. You can see there are nearly 500 folks hospitalized. And of course, the families of those 39 folks who passed away last week are forever impacted as well. So I hope that we are on the downside of the Omicron wave, but we do still have significant impacts in the community.
Thank you, Doc. And we've got some new information on vaccines.
That's right. It's an exciting morning for vaccine news. They timed it really well for our press conference today. We have 3 news items out of the FDA. So the first one is that Moderna has been granted a full approval for their mRNA vaccine for ages 18 and up. And that is the same Moderna vaccine that we've been giving for over a year now, since December of 2020. And their brand name is going to be SpikeVax, which is a pretty cool name if you ask me, but it is similar to the way that Pfizer became approved and has a brand name of Comirnaty. It's the same drug. They're just slapping a new label on it. The second piece of news is that the Novavax company has applied to the FDA for approval of an additional COVID vaccine for ages 18 and up. Novavax, their product is more similar to the traditional vaccines that we've come to know through childhood vaccinations and boosters for adults, things like the pneumonia vaccine and the meningitis vaccine. The Novavax product will be a 2-dose series, 3 weeks apart. And so there are a few people out there who are not able to receive an mRNA vaccine for particular reasons. And those people may be eligible for this product. And there may be some folks who are just not as comfortable with the mRNA technology. It is rather new comparatively, although we have given billions of doses across the world now, and I think it has a very good safety track record. The third and final news update from the FDA vaccine panel is that Pfizer is submitting their application for the vaccine for ages 6 months to 4 years. They are submitting as a 2-dose series, 21 days apart, similar to the way that the 5 to 11-year-olds get their vaccines. Previously, their initial data release suggested that there might be a little bit less efficacy in this age group. And so we're looking forward to seeing what new data they've produced. I know they did investigate a 3-dose series, but they have submitted the application for the 2-dose series just the same way that everyone else is getting theirs. Given the rise in hospitalization in the young pediatric age groups, the FDA made the suggestion that they go ahead and apply so that we can start protecting these kids as soon as possible, with the note that this is the only age group that's not yet vaccine eligible. So being able to get a vaccine to these kiddos will be, I know, a source of relief for many parents out there. We look forward to seeing what the FDA panel puts out, and I anticipate that the CDC panel will subsequently meet to endorse that recommendation when it comes.
No, I hope so. Source of relief for parents and grandparents too. Don't forget that. All right. Any other news, Doc, you want to share with us?
I think that's all of it. We've got big vaccine news this morning, so we'll be watching the FDA panel to see what they put out.
Yeah, that's amazing. Fantastic. Okay. All right, Kathy, back to you.
Well, Mayor, I don't see any questions in the chat, so maybe we will just give it, oh, there we go. Here comes one. From Gabrielle, what was the age range again for the new Pfizer application for 6 months? And 6 months to...
Yeah, Gabrielle, that is for age 6 months at the bottom end, and then up through age 4 at the top end. So it would cover that entire range. Once you turn 5, you're already eligible. So everyone between 6 months and not yet 5.
2-dose series, how far apart?
21 days.
Good. Nice. And how will that be administered?
So the logistics of it will be the same as what we're seeing for other kids, as far as very small volume intramuscular injection. The CDC yesterday said that they expect most children in this age group to receive their vaccine through their medical home, which would generally be their pediatrician, sometimes a family practice office or other healthcare provider. And we anticipate discussing this rollout with our task force later this week, so that our local area will be prepared when the vaccine is approved, and we can make sure that kids have access to it as quickly and efficiently and equitably as possible.
Perfect. And Dr. Patton, that's kind of a question for you. Okay, so we've got development like this. How do you, as a community medical director, push that out to folks that may not be listening to the news?
Well, the biggest thing is using sources that we've already had established and connections with trusted leaders in the community. So really talking to different community groups and see if we can get them talking to the people as well. We've partnered with different radio stations to get that message out as well, and different churches. So I think that's a big part too, just acknowledging and letting the people know that, hey, we have new recommendations out there. So.
Mm-hmm. Dr. Miller, anything to add on that through U of L Health?
I think that's right on. We are using similar techniques.
Perfect. Okay, Kathy?
Okay, the next question is from Adam Raymond of Spectrum. With the Omicron variant retreating, is there another variant on the way that's of concern? Dr. Hartlich, you want to address that?
Sure. So Omicron remains the dominant variant in Jefferson County and in certainly in most of the United States at this point. We have multiple subvariants of Omicron, but at this point, greater than 95% of cases are Omicron. We still have a very small amount of Delta in the background, but we don't see much of anything else. The CDC and the World Health Organization do track variants as they arise worldwide. So there are a number of categories there, variants being monitored, of which there are a whole lot, variants of interest and variants of concern. The only two in the United States that are currently classified as variants of concern are Delta and Omicron.
Okay, thank you. And then I think you may have answered this, but April Rickert of WFPL is asking if the new Omicron strain has appeared yet in Jefferson County.
So each variant has many subvariants underneath it. Delta has over 100. Omicron has at least 5, and the one that April is likely referring to is BA2, which is a subvariant of Omicron. BA1 is the one that we've seen the most of. BA2 is the second subvariant. We definitely have it in wastewater. They have confirmed human cases in many other places in the United States and worldwide. It is a little more difficult to identify on testing as being BA2. So it requires some sequencing. We don't have any completely confirmed human cases here in Jefferson County yet, but likely we do have some circulating.
Okay, thank you. This question is from Andrea Ash of WHAS 11. What trends signal the pandemic may have run its course and may not be as big of a threat? What will the end of the pandemic look like? How can we move on? What a great question. I know, Dr. Hartledge, you often say you want to look into your crystal ball, but I feel like maybe each of our guests could weigh in on this. And we'll start with you. What do you feel like will be a signal that we're nearing the end of the pandemic?
Sure. So, Andrea, I don't know if you'd like to chat for several hours about the answer to this question, but the brief version, I would say, is that when the pandemic reaches its endpoint, I don't think that we will necessarily know it up front. I think we will recognize it in retrospect. From an epidemiologic perspective, we need to see the replication of the virus and the transmission of cases reaching a stable number. So people will continue to get infected, will continue to get ill, but we'd like to see that number at a more stable background level rather than these in very large rises and falls that we see with these variant waves. I also believe that vaccines and treatments are very good tools for helping us reach that endemic point where we can have a long-term stable relationship with the virus. But with that said, there are billions of vaccinated people in the world, but unfortunately also billions of people in low resource countries that don't have access to the vaccine. And until we are able to achieve global vaccine equity, that we're likely to see continued rounds of variant development and subsequent waves of virus like we saw with Omicron or Delta.
Okay, anybody else want to weigh in? Perhaps Dr. Miller, Nurse Manson? Mayor?
Well, I'm not a physician, but yeah, how we transition to this being endemic in our population is what Dr. Hartledge was talking about there. So managing it much like we do the flu, and we don't know when we're going to get there because Dr. Hartledge's point about global equity is a big issue. And, we're just so connected now globally through travel. And we've seen that throughout the various stages of the virus where, it first shows up in New York City or on the West Coast and the more highly populated travel areas. We're going to continue to see that. But there's nothing that I'm aware of right now that's shouting at us from foreign countries or major population centers that we've got a new strain of the virus working right now. But the one thing we've learned, Kathy, is what? Be humble to the virus, right,
Yes, sir.
Dr. Moyer? So just like we think that, hey, we think we might be seeing the end of this. Last time we did that, it came back and punched us in the nose. So what we do know is the more people that get vaccinated, the higher the likelihood of this coming to an end is.
Okay, thank you. This question is from Sarah Ladd. As we look at the cases being on the decline, can you speak to the curve of deaths? And might we still be looking at a lagging spike there as we've seen with other variants? Dr. Hartledge?
Thanks, Sarah. You are correct that we have seen with every successive wave, the first thing to rise is case counts, hospitalizations follow, and the deaths rise afterward. We we're very lucky and grateful that the Omicron wave in general was less severe infection for many people, but many is not all. And so we have still had 500 people in the hospital. We have had deaths that arose from this variant. So yes, you are correct that the deaths rose a little bit later. They are, I think we're climbing that curve now, and hopefully we'll start to see the decline. And as you alluded to, we have generally a longer tail. So the case counts rise very quickly, and then it takes a long time for them to reach back to the baseline. Hospitalization numbers tend to rise very quickly and take longer to return to baseline. Same thing with the deaths. There are parallel curves. So yes, that I would assume that would be correct. We will see a lag. They are going up now, and that we will see a longer tail on that curve as we trace it out.
Okay, thank you. That was our last question. And Mayor, before we close, I would like to point out on testing, we have added a couple of new testing providers and numerous pop-up testing sites. So I just wanted to share that with everyone and ask people to share that as well. There are still many, many locations where someone can go if they need testing. And with that, I'll turn it back to you.
Okay, thank you, Kathy, and thanks, everybody. You can find the location of those testing sites in the chat if you want to do that. Want to thank the CEO of the Kentucky Nurses Association, Delanor Manson, for being with this effort from day one. Thank you so much for being with us here today, as well as Dr. Miller from U of L Health and Dr. Stephen Patton from Norton Healthcare. You all been through this marathon with us and have just shown great leadership. So thank you for being with us today. And then also thank you for putting a spotlight on health inequity, what we can do about that. And thank Dr. Sarah Moyer here for directing our whole public health team with our health equity efforts. And what we've been able to see in our city is unusual in terms of no disproportionality. So I know I speak for the team in saying we will continue that high effort focus. So Dr. Moore, you want to close us out with any words?
Sure. I just want to repeat what Dr. Miller said. I mean, we've had some successes here with COVID, which means we can solve some of our other inequities if we put our resources and come together as a community. So looking forward to using our lessons learned from COVID in years to come to try to close that gap. So appreciate all of our guests today and the partnership these last few years in working towards COVID, and looking forward to more going forward.
All right. Thanks to the media for continuing to cover this as we get healthier as a community, and we'll look forward to reconnecting next week. Take care.